So good morning, good evening for those of us joining us from various parts of the world. I'm sure there'll be many more coming in, especially because we invited our associates from AICS to join in this. This is a special webinar in which we disseminating the findings of a pilot program that looked at, adopting evidence-based program, keeping it real, to address substance use among adolescents. And this has been works in about 3 years now. And I'm going to explain briefly on how that journey has been as we've come along with Arizona State University through this. This is supposed to take us about 1 hour, and as you can see on the screen, we do have the outline for the presentation. So shortly I will invite the panelists to make a self-introduction, and then I'll go into the background of this study and why we are doing the dissemination now. And then I will invite Dr. Flavio Marsiglia to be able to present to us an overview of substance use. Then we'll look into the results from the pilot study and then invite you for any questions and just give a hint into some of what we are thinking as the next steps. Great, so at this point, I want to invite Flavio. Kindly go ahead and introduce yourself, your affiliations, and your role and interest in this project.
Very good. Well, thank you. Thank you very much. Good morning, good evening, everyone. I'm Flavio Marsiglia. I'm the director of the Global Center for Applied Health Research and also a professor here in Arizona State University. I hope that everyone connected today is in good health. And I bring you greetings from the president of the university and all the faculty, all the staff members. And I hope originally to be able to do this in person in Nairobi. We enjoyed our previous visit and we were looking forward to be there with you. But as you know, we're all facing serious limitations about traveling internationally. But I hope that I will be able to see everybody in person in the next few months. My role in this project is I'm kind of a cheerleader for the project. I think this work is very important. We enjoyed very much the collaboration. We enjoy meeting the children in the schools, the teachers, the enthusiasm for this work. And the need is there, as it is in all the countries we're working with. And this is an exchange of ideas and knowledge. We are learning very much from the experience and look forward to a long partnership with Samuel, his team, the schools, the authorities, and I thank you for the opportunity.
Thank you. Stephen?
Good morning and good evening. My name is Stephen Koulis. I'm the Director of Research at the Global Center for Applied Health Research and a Professor of Sociology at Arizona State University. And I have been involved, had the pleasure to be involved with the Keeping It Real program and evaluation of it in many different settings and several different countries, as well as many of our efforts to investigate the extent to which the program needs to be culturally adapted and carrying out those adaptations and testing the efficacy and effectiveness of the program in different settings. So it's been a great privilege to be involved in prevention work, especially focused on substance use prevention for early adolescents. And it was a delight to meet Samuel in person many years ago when he came to the center and worked with us for several months, as well as to meet people in Nairobi connected to the project, which was also a great privilege for us. So delighted to be sharing some of the fruits of the labor tonight and today. So thank you.
Thank you, Stephen. Thanks for that memory. Remind me when I was in Arizona, and indeed this has been a journey. For those who are listening, my name is Samuel Munyui. I'm a public health trained person, and I do head the research section of African Institute for Children's Studies. We are a non-profit organization, Pan-African, and we do have offices in Kenya, in Uganda, South Sudan, Zimbabwe, and we're expanding. We do believe a lot in the spirit of Ubuntu, you know, that says, I am because you are, meaning we can only have a better world when we take concern for each other, and that includes learning from each other on what is working. And so that spirit really informs this work with Arizona State University through the Global Center for Applied Health Research. And where we work from, our office is on Mombasa Road. And indeed, we did notice that there's been quite some issues around substance use, and we thought we could learn from this program. So welcome, and we look forward to not only sharing this, but hopefully interesting you to collaborate with us more. I will, along this, give a quick summary of who has been involved in this process. So we've already mentioned the African Institute for Children's Studies, the Arizona State University through the Global Center for Applied Health Research. We want to acknowledge this support from the National Institute for Health in the US, the National Authority for Campaign Against Drug and Alcohol and Abuse. And we actually have an MOU, and this is contributing towards the evidence-based interventions that we can scale up as a country. And they've really worked with us in this journey from the needs assessment. The Institute for Curriculum Development in Kenya did review the training curriculum or the student and the facilitator tool that has been used, and you know, basically to inform what needed to be changed in the initial stages. And this was also partly contributed to by Daystar University. We had reviewers from the university. We went through an ethical review process, and NACOSTI, which is the National Agency for Research and also responsible for approving all research, went through our documents. We want to appreciate the county governments of Machakos and Nairobi, and the Ministry of Education, whom we've had meetings with, and the participating primary schools in Machakos and Nairobi, that is Mlolongo and St. Paul's at the river, and Jacobena and Mihango in Nairobi County. And indeed, all the stakeholders have been part of working with us, asking us tough questions. This is really what it means to develop an evidence-informed intervention. Welcome, and thank you for the support. I wouldn't belabor much again on the background. I've already hinted to some of this, that we did start off because there was data showing that there is a large proportion of children, relatively, I know in some countries this could be much higher, that are into substance use, especially tobacco, alcohol, and bangi, as we say it here in Nairobi or in Kenya, cannabis. So when we looked at data and research reports that are being documented or in the library of the National Alcohol and Drug Abuse Authority, NACADA, data shows that there seem to be, you know, relatively high knowledge level or proportions of children who have some information around these drugs. About 16% are smoking, and we are talking about children in their early teen. And we also see from those graphs that looks like this peaks during holiday. So you can imagine the COVID impact that could be coming out of this, which again, perhaps is a very timely moment to reflect and converge the stakeholders to prioritizing the interventions around substance use, considering the long holidays, so to say, that schools have had to do. But despite all this understanding, there are very few evidence-based substance prevention. There are a number of stakeholders who are working with the NACADA in terms of response to drug abuse or alcohol early use by young children, 11 years, as it says here in the median age. But there are very few that are doing prevention. And yet we know that in any behavioral intervention, public health intervention, then prevention really works much cheaper than doing curative. And also if you look at the effect on the disability and life of people, then it's much more better if we invest more in prevention. But again, you don't want to go into a large scale and invest as a country in methodologies or interventions that we do not know what the feasibility or the likelihood of it happening in terms of being effective is. So this is really an opportunity for us to then be able to present what could work. And we are not saying that you've got to eliminate everything else. We think the more we test out our interventions and even have an answer that says it doesn't work, that's equally a good answer that sometimes programs don't have the benefit of doing. So we think this sort of collaboration with universities will enable us to test out models before we invest heavily in public financing in some of these interventions. In this particular work, we also appreciated that when you engage in this collaborative research, we need to build capacity. And there were elements of also investing in the physical infrastructure to deliver. So I think before we thought about online schooling, we already last year presented equipment that will enable them to do some digital support to learning, use audio because audiovisual is a very powerful tool of doing this. And we believe this is something that needs to go into our budgets as a country in investing in adequate infrastructure. Lastly, in my introduction, I just want to point out to the overall objectives that we did have, that we are looking at, like I've already emphasized, having an evidence-based intervention that can be tested. And this has already been done in other countries. I will let Flavio present that, the other countries where they've done this. And in any behavioral intervention, again, the element of cultural appropriateness is definitely very, very critical. So while there may not be need to do this from zero, develop new curriculums, how culturally appropriate are those ones that we are able to import? What adaptation do we need to make? And that is the essence of the conversation today. We hope to contribute to the body of knowledge and possibly reduce or delay substance use among young people. We know there's a lot of benefit even in delaying it, say from age 14 to age 18. There's much more reduction in the consequences and the cost to the public health system. We do hope to, like I've already said earlier on, enhance collaboration, not only between Arizona State University and the African Institute for Children's Studies, the government agencies. We've been working with Daystar University. We hope to expand this kind of collaboration, even in building beyond this pilot intervention. So once again, I want to thank the ASU community and indeed the rest of the agencies we've worked with. Let's look forward to more working together to share the knowledge and not reinvent the wheel. Over to you, Flavio.
Thank you, Samuel. Well, I will briefly provide an overview of Keeping It Real. It's an evidence-based intervention and that we started to develop many years ago. This version that we use now is over 20 years old and has been tested and implemented in 16 countries at this point outside of the US and across the US in 48 of the 50 states. Next. We call it a use-inspired intervention because it was born out of the need for an intervention in Arizona, the state where we are located. because many of the interventions that were available were not responding to the cultural needs of our population. Then from the start, the cultural component of the program, we call it cultural congruence, is very important. And we see culture as a resource that will help the child connect to the message. Then we start with the need, we develop the research project, and the research project brings about a solution to the identified problem. And that cycle continues throughout the life of the research project. Next. It's a theory-based intervention. A key element of our theoretical background for the project is the ecological risk and resiliency theory, and uses the place where the child lives, or the young person lives, as a resource again, and as a way of locating the intervention in a very specific place. Even within countries, as you well know, in Kenya, there is great diversity. Then always there is a component of landing the project in place. And another element is, as I mentioned earlier, is culture. It needs to be grounded in the local culture. And that's part of, language is part of that, but the adaptation is more than linguistic. Often we share the English language, but for example, but then culture may be very different. Even the version of English may be different. As we experience in Kenya, the adaptation also implied or was a linguistic adaptation from American English to Kenyan English. Next. Keeping It Real is a prevention program that is very much following the life skills model. The idea is to provide children with tools to be able to use when they experience risky situations. It's not to scare children. The purpose is not to scare anybody. It's not to reprimand children. It's to prepare children for risky situations. Often we have found in research that the great majority of young people do not want to use alcohol or other drugs, but when they are presented with an offer, they're not prepared to deal with it, to manage that offer, and they start using as a default. If they have skills, tools to deal with those risky situations, they can navigate that much better and successfully. Then the idea is to have a repertoire of strategies to use the right strategy in the right situation with the right person offering. Then the 4 strategies that we identified from our research working with young people are refuse, explain, avoid, and leave. Those are the 4 most common strategies young people use to successfully refuse or navigate risky situations. Then based on the 4 strategies, we then build the whole program. And the original research compare doing this kind of intervention in a community setting outside of the school, or doing it in the schools. In this case, our middle schools in the US, 7th grade is when the children are 13 years old, 12, from 12 to 14 years old. And we found that if the teacher, the classroom teacher, implemented the intervention, we got much stronger and consistent results, because the teachers already are experts in teaching. They know the children, and they provide consistency and continuity for the program. Then those were the factors that we identified as the best factors. And the children go to school every day we hope, then they provide consistency of attendance. When this is done in other environments, it's more difficult for the implementer to be there for every session, or the semi-implementer, and for the children to be there every session. The program has 10 sessions, and it's important that the child, the student, the pupil participates of all the sessions. We then are doing work in many countries, and one of the countries that we are blessed to be working with is Kenya. And this is a bit of a summary of what happened with the work we did here, and I will let Dr. Kulis help us review quickly some of the key findings. Thank you.
Sure, thank you, Flavio. We have some preliminary evidence from the pilot project that are ready to be shared out, and they have to do with sort of preliminary estimates of whether the intervention can be efficacious, that is, effective under controlled circumstances, and also some results that bear on whether the intervention and the curriculum was acceptable and applicable to the students who were receiving the program. So we have a few slides that give a flavor of that. So Samuel's team in Nairobi were able to recruit schools from Machakos and Nairobi counties, and there were 4 schools in the pilot project. This occurred, the implementation occurred in the 2019 school year, I believe. And 2 of the schools were assigned to be the intervention schools where the curriculum was delivered, and 2 served as a comparison or a control group. So the randomization was at the level of the schools. And we had a pre-test, post-test design. That is, there were surveys or questionnaires that the students filled out before any intervention activities occurred, and there was a post-test afterwards. And students in the implementation and the control schools both completed those surveys. So at pre-test, we had, or altogether, we had 841 students supplied pre-test or post-test or both. And there's a slight gender imbalance in favor of females in the sample. And these were students in their final year of primary school. So on average, they were about 13 years of age. So the first slide that we want to look at next has to do with what we discovered from the pretest prior to the implementation of the program. And so what we have here are prevalence rates and percentages of students reporting whether they had ever used alcohol, tobacco, and we have it as marijuana rather than cannabis. And what you'll see here is almost a quarter of the students said that they had some experience of using alcohol. It's about 23%, and about 7% tobacco, and a much smaller percentage, close to 4%, had used marijuana in their lifetime. And actually, from the perspective of the US, where we also have information about the prevalence of the use of these substances among 8th graders, who would be about the same age. These are very similar to US figures. In terms of exposure to opportunities to use substances, you'll see here that less than 10% had recently received an offer of alcohol, tobacco, or marijuana. But this was in the last 30 days. So if you multiply that over the exposure of a whole year, those figures would be much higher. We like to focus on recent or last 30 days because it's a more reliable measure of what the students have experienced. And then we had a question about how the students react when they are feeling pressure to do something they don't want to do, like use substances or do something dangerous. And this was sort of a preliminary look at whether they're already familiar with the real strategies. And what we see here is that very large minorities, up to half of the students, had said that they would use one of the real strategies. So that provides some level of confidence that these strategies are already familiar to the students and could be employed in a risky situation. So those were some pre-test findings. And the next slide shows some post-test results. And so here we have changes from pre-test to post-test. These are means, mean values in the control group, the 2 schools in the control, and the 2 schools in the keeping it real or intervention condition. And again, these are just changes from pre-test to post-test, so they don't look like very large numbers. But what you'll see is that there are actual reductions in use of alcohol in the keeping it real group, and also more serious use of alcohol, like heavy episodic drinking or binge drinking. Whereas those things, the means are going up in the control group for alcohol and binge drinking. There's also a gap in marijuana use and very little difference between the 2 groups in terms of cigarette or tobacco use. But what we're seeing here are trends towards the desired prevention effect for alcohol, binge drinking, and marijuana. The next slide focuses on really, in addition to, and in some sense, even more important than showing results for actual use of substances, is to show some change in attitudes towards substance use, particularly to reinforce or preserve anti-drug norms that the students already have. And we have several measures here that illustrate what was going on from pre-test to post-test. We asked the students whether they think it's okay for someone their age to be using different substances, alcohol, tobacco, marijuana. And those are called personal norms. We asked them how harmful do they think use of substances is, whether they can expect negative things to happen as a result of substance use, and also whether their parents disapprove. That should say injunctive norms. Sorry, there's a typo there. Whether their parents disapprove of their own use of substances, the students. And what you see here are trends in the desirable direction for the keeping it real group, improvements or preservation of anti-drug norms, whereas in the control group, there's either a decline or really backsliding on those measures. So those are desirable effects as well. The next slide is just the students in the intervention group, the keeping it real students, and these are post-test questions that we asked them about the program. And so we asked them what they thought about the program overall and its different components, videos, homework, and class activities. Did they like it, love it, did not like it, or hated it? And you see very, very, very large majorities, pluralities, saying that they either loved it or liked it. So there's pretty universal approval and satisfaction with the program. The next slide goes to some more specific questions about whether the program really is relevant and applicable to the lives of the students. And again, we have 4 different response categories, going from strongly agree in blue to strongly disagree in red. And this is a selection of the questions that we asked them about the program, whether it was realistic and believable and like their own lives and like their peers, whether it was easy to pay attention to, whether it was fun and interesting, and also whether they thought it was giving them helpful information. And again, we have very large majorities saying that they strongly agree or agree with each of these statements. So in general, pretty strong evidence that the students find the program is applicable to their own lives. So in conclusion, we found desirable effects on substance use behaviors and substance use attitudes, as well as a very high level of satisfaction from the point of view of the students and their view that this program is really quite applicable to their own lives. Thanks.
Thank you, Dr. Collis and Dr. Marsiglia. Flavio. At this point, I think I have Dr. Lumbe in. I just want to give a chance to anyone who was part of this, if they have any word or two they want to add to this. I saw Nelly from Machakos.
There's also a question from No.
Olumbe, are you there?
Yeah, I am. Sorry,
any reflections?
I know I joined when you had already, sorry, good evening to all of you, or good morning to those who are in the morning hours. I joined in a bit late because I had in a meeting that ran in late. But just to go back, I know one of the things that I participated on this was to check the relevance of the manual and how it fitted for the kind of targeted group. And I think in my evaluation and understanding, it was a very, very appropriate material, especially for young school-going children, that would really be helpful in really promoting, first of all, positive values as we work towards prevention of substance abuse and just talking about the life skills. So quickly, maybe because I hadn't prepared to make a speech, quickly to say, yes, it was down to earth, it was simple, it was easy to understand for children. And I am almost sure, since I have not maybe looked back to find out what was the impact, what I'm convinced that it made an impact in the lives of the children, especially the simplicity, the artwork in it, and the use of communicable information that children of that age would be able to use. So good work, well done, and very well informed, especially the science behind it based on some research that have been done, made it a stronger manual or document to be used. Yeah.
Thank you, Dr. Lumbe. Permit me to add that we have an active collaboration between the Institute for Child Development at Daystar University, where Dr. Lumbe resides or works from, and the AICS. So I believe some of these messages or results that you're finding, we can find space to enhance collaboration in research, even in Kenya. Thank you very much.
Okay, welcome, Sam.
Thank you. Is Nelly or anyone from the schools available? Okay, anyone from KICD? Olango? Okay, great. So maybe it's that moment also that I can actually open it up to, oh, there's a hand up? Okay. There's someone using Nokia 3.2. Do you want to give? I'll open it up to anyone who has a comment, a question to the panelists. Nokia 3.2, you can identify yourself.
Sam, I do see a question in the chat.
Kindly read it, Christine.
Sure, it's from Noah, so I don't know if Noah wants to unmute and ask the question. Otherwise, I will say the question is, oh, go ahead, Noah, go ahead.
Yeah, I'm available. Hello, everyone. I am Noah, and with AICS Zimbabwe. Thank you for that wonderful piece of research on drug abuse. But of late, I have noticed another drug, which I called digital cocaine. Obviously coming through the smartphones and you name it. And I do believe for some children, this could be the foundational reason why they then move to those other drugs which you listed. So since your work is ongoing, are there any thoughts or considerations to layer this other drug on the ones under investigation? Thank you very much.
Thank you. I will let Kulis or Flavio come to that. Maybe is there any other question before they take on that? Comments?
I can start, and then maybe Dr. Kulis can continue with an answer. Thank you, Noah, for the question. I think that's a very good point you make as an example of context. And that's the idea with the adaptation of the program. We need to address the needs of the context in which children live. And drugs change, as you know. It's a business, and then the products keep changing, and the market keeps changing. Then I think it's important to respond to what the children experience and the risks they face. But we believe that the strategies we teach can be applicable to many different drugs and to many different situations, even separate from drug use. We have found in some of our studies that these strategies are applicable also for sexual risk behaviors, for example, or violence prevention, bullying, for example. Then, although we need to be inclusive and incorporate new drugs, we believe that the program is a universal prevention program that addresses the needs of many children, and we can incorporate additional content like new drugs, but that will change over time and from one context to another. Dr. Kulis, would you like to add?
Thank you, Flavio. It's a very good question, Noah. Just to add one thing to what Flavio said, which I think is very important. The program teaches not only very specific things about drug use, but more general strategies about risk assessment. So I think that can help the students in many different situations, as Flavio mentioned, make correct choices, be able to review what are the opportunities that they have to respond in different ways, and keep perfecting their repertoire of strategies for handling difficult situations. Again, it's possible to incorporate more targeted and very specific information about drugs that will apply to a particular context. But I think our experience has been that the more general training in risk assessment and decision-making skills and repertoire of strategies for handling them is probably the most important part of the program overall. Thanks.
Thank you, Kolisa. Indeed, I want to add that in line with digital addiction, so to say, and misuse of it, as a program at AICS here in Kenya, in the last 2 years, we've implemented a curriculum-based program to help children know how to effectively use the online media and prevent sexual exploitation. And we actually built it or modeled it around using the real, the 4 strategies. And while we have data that we are yet to finalize in analyzing, that looked at, was it working, what was the acceptability? But I would want to say, even from preliminary observations, indeed, it's an effective way of building capacity for any young person to know how to reduce exposure to risky behaviors, whether it's online or in other ways. And the same curriculum that we used for that, or the training manual, was evaluated by KICD, Kenya Institute for Curriculum Development, and approved. And we are hoping to launch it and have it adopted by the Ministry of Education and other stakeholders. So I think the approach is a good skill.
Samuel, I just want to say one thing more to Noah. Our colleagues in China, mainland China, are facing the same challenge about digital addiction of their children. And they are adapting Keeping It Real for China right now with us. And they are very concerned about that, and they maybe that would be good. I mean, the purpose of our center is also to connect country to country. Not all knowledge has to come through the US. Then maybe if you are interested at one point, it would be good to meet with our Chinese colleagues and also exchange some of those ideas and experiences and see, what we can come out together. I think we are sharing that across the globe. Our young people are very much exposed to these challenges, and internet and Wi-Fi and everything else is a resource, but also can be a challenge in some cases. And now with COVID-19, even more, because they are on it all the time, even going to school virtually. Then that would be an opportunity for us to have an exchange, maybe eventually in the future, just as an idea for collaboration.
Sure. Thank you. I want to invite Nkezo Olaya, Christine. I know you spent some time looking at this data too, before we look at the recommendations. And again, based on the recommendation, if there's any further recommendation, we can conclude and talk about the steps forward. Anything you want to add, Christine, Olaya? And Olaya, you could add what you're doing about this in Spain, or the vision. Yes.
Yes. Hi, everyone. This is Olaya Kudrin. I'm a postdoctoral researcher from Spain. And yeah, I think the next steps with the Kenya project will be more useful to can adapt the program to your culture, and especially the qualitative data that they are going to collect with teachers surely is going to help you to get a program useful in your country. And we also implement a pilot study in Spain of Keeping It Real. And we found similar results in some kind. And I don't know, I think we have to work together to can move forward in prevention on drug use in adolescents.
Thank you, Laia. We look forward to learning from Spain, and maybe even at this stage, what Dr. Collis presented around the profile of substance use in adolescents in Arizona didn't look very different from Kenya. Looks like despite economic wealth of countries, substance use seems to be a common language. I wonder how common it is for Spain too. I guess you still don't have the data as much yet, but we'll be looking forward to learning from that. Christine?
Sure, I'd be happy to add that I think along the same lines to what you just mentioned, that I'm very excited because we're also launching a pilot of this in South Africa, and are looking to launch in a couple other locations, a pilot in a couple other locations in sub-Saharan Africa. And so I'm very excited to see this work in Kenya continue to guide and inform that work as we expand in the continent, and then to compare the results to really bring this intervention to more countries and to really have a bigger impact on, or larger impact on the youth of sub-Saharan Africa.
Thank you. I've seen a few of us have joined. Maybe at this stage, allow me to run through the recommendations. And then I've seen some friends of AICS who've joined, like Honorable Justice Martha Koome, who is our child rights champion and has been served as a deputy, chair of the African Committee of Experts. And I see Catherine Mwangi, who's also been a practitioner. As we finish, I will invite any further comments, but your thoughts around what can we do to even make this better. So like we started off, I explained that this program relationship began with my research fellowship at Arizona. And of course, knowing the gap that we have in prevention science or prevention interventions. And we always say prevention is better than cure. And into a needs assessment that took us about 6 months that confirmed that we needed this kind of intervention. And so then the need to try and adapt what exists from Arizona. And Flavio, Dr. Marsiglia, I don't think you've said much about South America. You could also just touch on how this links to what you did there. So really what we are looking at based on the two conclusions that we did make, I want to go to the conclusion that keeping it real as a substance use prevention is something that we require and desirable among primary school children. And I think there's a science behind doing it for that age cohort that we have. About 10, 14-year-old is a good stage when you do prevention science. And that the satisfaction that it can be applied. So in terms of recommendations, that then we continue doing the investigation on how to make this much more adaptable. We have used videos that were used in America. We'll want to see whether there's how much changes we need to make it much more adaptable. But overall, it can be used. So that's where we are at. Again, continuing building the capacity of working with schools, the Ministry of Education and teachers to be able to get their input into this and to build their capacity to use this kind of a module in the intervention. So we hope that once we get through with the next phase, which will be now a trial on the efficacy, does it work? Because now we know it's acceptable. We sort of have an idea of some of the minimal changes that would need to be done, being conscious that we need to keep to fidelity of the intervention. Now, how can we scale it up? How can the Ministry of Education take this up? How can NACADA take up this and maybe even look along the other interventions and perhaps say, in Kenya, does it matter which part of the country you are in? Maybe the other interventions that are being used will be appropriate in urban setting, others may be more appropriate in a rural setting. So these are things we need to do before we really call on the government to invest more from public financing. Once again, before we go into closing, let me invite anyone else with any additional thoughts, any questions to give their voice on this. Yeah. And I know as hoping Judge Koome, if you are able to speak, I know we in the National Task Force on Administration of Justice and the issues of access to justice for children, we are all very concerned of the increasing number of young men, especially, who are spending time in jail, and some of these things like sexual exploitation or defilement, rape, are sometimes linked to substance use. I believe this will be very important to us to think about how does this link with the justice system. If you're able to give some thoughts, it would be really nice. And if you can be on camera on. Otherwise, I'll open it up to any other thoughts.
Yes. Hello, everybody. Yes, I'm speaking from that corner, but I think you can see me at the webinar. I've just dreamed of this very informative topic, which, as you have summarized very well, bothered us because from the administration of justice, we are actually convincing with the perpetrators it is not normal. It's linked to, substance abuse, alcohol abuse, especially the young people who are found in conflict with the law, and fighting very small children. Satan entered their end. I don't know how Satan enters somebody's end other than through substance abuse. It's opening up one of the silver linings in COVID-19 has led us to go deeper to find out why some things happen. We are now focusing on mental illness because of it has been exacerbated by the COVID-19. We are also concerned about psychosocial support, especially to the victims, all because of the stresses that have come with the COVID-19. I think it has made completely timely this call this news because I can say from where I see it that it is the one that contributes to so many of our young people who find the law. So targeting the schools, like have had you summarize, Sami, as an avenue of intervention will be completely timely because from my own family, I'm dealing with cases of my nieces and nephews who have gone in substance abuse, and I'm telling you, rehabilitating them is not easy. So if we can aim at prevention, that would be the thing with one piece or the other of substance to this conversation before it ended. Thank you very much, and thank you so much, the excellent presenters, even if I'm not, and I'll catch you on the YouTube.
Thank you. Thank you, Judge, for making time to join us and also representing our International Advisory Board for AICS. And indeed, the linkage with COVID, with access to justice, mental health, I think really you can't overemphasize the importance of addressing substance use from a prevention point. I see there was a question around, can you use keeping it real in emergency situation? This is someone who's worked on child protection in South Sudan, even Olango. I think that's good. And there's a feedback here from KICD, Dr. Ngina, who is from the Kenya Institute for Curriculum Development. Thanks for just emphasizing that this is important. And indeed, we look forward to further collaboration, giving you feedback as KICD so that we improve even on the manual that you did review and approve at that moment. And let me add that I think as a country, we also need to engage this or strengthen the nexus between practitioners, researchers, and communities, because that way then we have a living laboratory from which we keep improving the kind of interventions that are important for our well-being as a society and as a humanity. Dr. Collis, Dr. Marsiglia, anything around the emergency or any parting shots? I think we have about 3 minutes or so.
Yeah, I think those are good questions, and it's applicable to emergency situations, but just to remind ourselves that this is more prevention oriented, not so much crisis or management oriented. Then although children who are experiencing a crisis need anyway life skills to cope with those stressors, that can be useful, but I think needs to be complemented by other interventions that are more treatment oriented. Then, as the judge mentioned, the psychosocial needs of children may need to be taken care by a multiple set of interventions and professionals. And the prevention part is only one part of that spectrum when it comes to complex needs, like the one mentioned.
Thank you. Dr. Collis?
Nothing to add. Thank you.
Thank you. Unless Dr. Ngina from KICD wanted to add something to this. Dr. Ngina?
No, I have nothing to add. Hello?
Thank you. Thank you, noted. And thank you so much for coming in, and we really hope to strengthen this. Apologies from Jacob Baduda, who is our focal point person from NACADA. I think he was caught up in some traffic and he wasn't able to be on his desk as planned, but we'll be able to present some of this feedback. And indeed, this is it's an ongoing collaboration, so we are not ending it just on this. Otherwise, thank you very much, everyone. Really appreciate you making time for this, and we will make available some of these publications and enable us to improve our interventions on substance prevention.
Thank you, everyone. It was a pleasure.
Thank you. Have a good evening, good morning, good day.
Yes.
Bye-bye.
Bye-bye.
Okay, thank you.